Hello, everyone. This is Mitch Buse with HCTec. I want to thank everybody for joining today. Today we're going to talk in some detail about how you can cost effectively support as well as optimize and advance your EMR. The EMR that we're going to focus on today primarily is going to be Epic. And a couple things as we go along. Everyone on the call on the webinar is muted right now until we get to Q&A. Feel free to jot down any questions as we go along, or you can submit your questions using the question window on screen, and then we'll handle Q&A as we get to the end today. As far as the agenda goes, we're going to do some brief introductions. We'll share a little bit about both HCTec as well as St. Luke's Health System. We'll get into some detail around client productivity review tied to some analysis done at St. Luke's as well as about 90 other hospitals running Epic across the country. We'll dive into our managed services team and what we do in the overview section. And we'll finish up with a case study that we did in conjunction with St. Luke's. And finally, at the end, we'll hop into the Q&A. Today, in addition to myself, the folks that are going to be on the call today, Stephanie McDonnell, who's Vice President of our HIT and Clinical Services, which means she heads up all of our consultants as well as our service center based in Atlanta. Rob Drucy, who's our Chief Technology Officer, and Debbie Gash, who's VP and CIO at St. Luke's in Kansas City. To share a little bit about HCTec, we're founded in 2010. Corporate office is in Nashville. As I mentioned earlier, our remote service center is in Atlanta, and we have a couple additional offices in Tampa, Steamboat Springs, Colorado. As you can see, we've got a pretty large number of consultants. I think it's actually over 1,000, and it's roughly 100 now in our managed services team in Atlanta. We're exclusively in the healthcare space, and we work strictly with hospitals and health systems. And you can see everything from large for-profit systems to academic medical centers to critical access hospitals. You can see our business lines below. What we're really going to focus on today is the third pillar there, the managed services team, where we do clinical support, application support. As I mentioned earlier, we're going to focus the discussion today around Epic. Epic is what St. Luke's runs. I'll let I think Debbie's going to share a little bit about St. Luke's.
Yeah, thanks, Mitch. St. Luke's Health System is a 10-hospital integrated delivery network located in Kansas City, Missouri. We have hospitals and clinics in both Missouri and Kansas, and our service area is about 100 miles around Kansas City, serving 64 counties in that service area. We have about 11,000 employees across the organization. We employ about 750 providers, 550 are MD, DOs, the others are advanced practice professionals. We have Epic as our core EMR revenue cycle management system, and have been implementing Epic over the last 3 years across our organization. The health system generates about $2.5 billion in revenue on an annual basis, and I think, like most organizations, been challenged with a significant amount of work demand as the organization tries to grow and prepare for value-based reimbursement.
Thanks, Debbie. So now we're going to hop into really the objectives around our managed services group and what we do. As I mentioned earlier, we did some analysis with over 100 hospitals of the last 2 to 3 years. As we thought about introducing our remote managed services offering to the market, these are the 4 areas that kept popping up with our clients. We've probably got over 100 or so Epic clients, and as we talk to them, these are the things that continue to bubble up. The top one, and they're really in order, actually. The most important thing, at least for the CFOs, was we want to be able to reduce our OpEx related to EMRs and specifically Epic that we're talking about today. Another thing that's really important was to also at the same time be able to increase the client's FTE project hour availability, because you want to be able to, you spend all this money on Epic and you want to be able to advance the system in the way that your end users would like. So that's always been a high priority. Improve employee retention, satisfaction. You have your highly skilled employees focusing on project work, which is what they enjoy, with little or no time spent on support. And finally, most folks want to dramatically reduce contract work. It's very expensive. You're paying 150, 160, 170 bucks an hour in some cases, and it's just not something that's sustainable. We'll hop in now to the productivity review I mentioned, tied to St. Luke's as well as the other systems. And most of the folks on the phone who run Epic, when you implement a system like Epic, what we've seen, our clients have an immediate increase in resources needed to support it. And when I say an increase, most clients that we've talked to and we work with have either doubled or even tripled in some cases the number of resources that they need to go forward supporting the system versus the system they were running prior. So whether you're running MEDITech or McKesson or Allscripts or whatever it might be, we've seen that increase double and triple in some cases, and that's, as you know, it's very expensive. Another challenge has always been, and this is not just related to Epic, but any system really, is you have your staff forced to continually switch between project work and support work, which then in turn can lead to heightened employee dissatisfaction and turnover. And then, as we talked earlier, hiring replacement staff or using consultants is very timely and expensive. For example, I think we'll get into this in a few minutes. Actually, it's on the screen. St. Luke's had about a 15% turnover ratio on an annual basis, at around 110 FTEs. So we're averaging about 16 FTEs per year as far as turnover. And and part of our analysis to replace an FTE, an Epic FTE who leaves, to hire and replace a person to fill that spot can cost anywhere between $150,000 and say $180,000. I know we got $170,000 here on the screen, but if you do the simple math, St. Luke's was looking at spending $2.8 to $3 million annually just on turnover and replacing people. So it's a very expensive process. So if you think back to the screen just before this, when I talked about the reasons that we rolled out the managed services approach here, it kind of mirrors this. This just is not sustainable, and that's the reason that we're talking to you today about this. as I mentioned, we've got a large Epic client base. The main things I like to focus on here, bullets 2 and 3. What we've seen in the analysis, roughly 65 to 75% of the time for your FTEs is spent on support. Time spent on advancing the system, is 25% or less. And once you factor in non-productive time, that drops down to 5 or 10%. And something we haven't talked about yet, but end user dissatisfaction. So not only FTE dissatisfaction can grow because of this, but end user dissatisfaction can also grow because you have, you're just not able to advance the system and optimize it as quickly or as effectively as they would like, as well as you would like. And going a little bit deeper into the productive time breakdown, this kind of breaks it down for you a little bit farther. And again, this goes back to the analysis, as I mentioned earlier, with the 100 or so hospitals. This is how it broke down, across all 100 that we talked to. It pretty much broke this way, across all clients. 30% of, and again, this is employee time, so FTEs, in this case, Epic FTE time breakdown. As you can see, non-productive time, 30%, time tied to support, 55%, and then project optimization, advancing the system, 15%.
And this is Debbie. I'll just interject here. That is totally reflective of what we were experiencing in our implementation, is this distribution of work effort. As we tracked our staff's time, the majority of their effort was spent on just keeping those systems up, managed, updated, et cetera, and very little demand capacity to respond to the demand for optimization and new initiatives. So this is exactly where St. Luke's was in our situation.
Thanks, Debbie. And leading to that, when you think about even further complicating things, you throw in fragmentation. And I know everybody on the phone who's listening to this can relate. This really talks about the employees who work on both project and support-related activities, and the constant switching back and forth on a daily basis, which is called context shifting, and it's not very efficient. Our brains were built to focus on one thing at a time and do it very well. But when you start splitting that, it becomes less efficient. And I remember Debbie telling us a while back that she does an annual employee survey each year, and within this team, I guess one of the things at the top of the list was, we feel like we work all day long and we just don't get things accomplished. And that's exactly the definition of this. And there's additional productivity lost from that fragmentation, as you'll see on the next screen. It just further reduces the amount of time that you can spend on actual project work. As shown here, you see the non-productive time increases, the project time decreases, which is, it's like I said, it's very inefficient. And there is a better way to go about this. And finally, on this screen, this is a screen that really gets people's attention. So if you think about a total FTE count of 120, you see there in the purple box, and then you look at the 30, 55, and 15 and how that breaks across that 120. So if you think about it in this way, you've effectively got 36 FTE, or the equivalent of 36 FTEs tied to non-productive time on an annual basis. And you can see the amount of money that is and the number of hours associated with that. The same thing goes for support. you've got the equivalent of 66 FTEs tied to support. And if you look at that bottom bucket, you've got 120 FTEs, and out of that 120, you've only got 18 actually advancing the system that you've spent so much money to acquire and to implement and to hire up people and train them. And our point here is there's a more efficient, more cost-effective way to do both, to support the system in an optimal manner, but also to be able to increase functionality, increase optimization, advance the system, get into Community Connect, and really get the bang for the buck that you spent the money for. So now what I'd like to do, we're going to get more into the overview of the managed services team and the model itself. I'm going to turn this over to Rob Drusey, our CTO, and Stephanie McDonnell, VP of Clinical, to walk us through these few slides.
Thanks, Mitch. Thanks for the overview you gave of all the preceding slides. So with our managed service offering, we have physical centers located in Atlanta and Nashville, Tennessee. Folks travel into those centers every day. They're working out of those centers 24/7. We felt that was important from a delivery model, that it really was in sync with how our clients operate their centers. We designed the offering day one to really just support healthcare applications, both the clinical system, the revenue cycle, and the general financial systems as well. And it is a leveraged model, so clients are really paying for the equivalent FTEs they use across the pool of subject matter experts that we have based on our service level agreements. In terms of the primary challenges and benefits, we're always looking to assist in improving IT quality and patient outcomes. And kind of how we do that is we're able to provide guaranteed levels of service, backed by our SLAs that we do continuously monitor. So we have technology we've implemented that on a real-time basis really lets us see what is the level of service we're providing, and if it's dipping below what we want, and more often than not, it's exceeding the service level. Another big benefit is that we're always wanting to increase the IT value to the business. So as Mitch alluded to earlier, and as Debbie said, we want to make the business see IT staff working on their projects. If they're not seeing the staff continually moving, the ball down the field, sometimes, they decrease the satisfaction they have with IT. And using our model really allows the organization to deploy their staff visibly, within the business, so the business sees the return on investment with, the precious dollars they're spending towards IT. Another thing that we look at is from a risk standpoint, having a managed service help support the day-to-day operations does mitigate and reduce risk. Our operation is definitely staffed where we have redundant coverage. More often than not, we're 3 or 4 deep in different certifications that are necessary. So, in terms of an organization having turnover, with our service levels, that really doesn't impact them. And then from a cost perspective, we feel our offering, has a very good value for the cost that we charge. So we do feel it does reduce the overall cost, and we welcome the opportunity to show folks that once we meet with them in terms of the model. So this slide really shows how does this all work, kind of the secret with the client and HCTec Service Center. So what we're really good at is on a day-to-day basis, we like to resolve issues. We like to fulfill service requests. We want to perform maintenance tasks, and we want to assist with application testing. We really refer to those activities as lights-on activities. The people we interact with on a daily basis, usually it's end users who are having problems. It's the client help desk. It's the client IT staff, so the level 3 support team that the client is retaining, and then it's application vendors. When we are able to effectively implement this, the client applications team really shifts towards more client-facing activities. Kind of as we said before, the business really sees the value at that point. So the client is really retaining the governance, new project scoping, They're doing the workflow analysis out in the field. They're looking at strategy and expansion, new functionality. They're still the lead on all the strategic and tactical decisions with the application vendors. They're typically retaining user management. And in terms of who the client is typically interacting with at that point, they're obviously still interacting with the folks we are, the end users and the help desk and the application vendors. But, primarily they're spending a lot more time with the providers, with the departments, with super users, with IT steering, because they're shifting their focus from support-based tasks really to more project-based tasks. And to ensure that our teams jointly deliver a defined, coordinated service model, we have scheduled communication points. So, our teams are working just as an extension of the client's teams. As an example, at St. Luke's, our analysts are on Skype with their analysts during the day. It's regular communication. We do have formal monthly communications where we're meeting with Debbie and her leadership team to review the service. We're looking at a go-forward basis, too, to make sure capacity and volumes and things like that are taken into account. We also have defined escalation points. So there are definite hiccups that happen just with any operation, and we definitely want to address any and all issues we have that are out of the normal. So we have defined escalation points where any person within Debbie's organization has the ability to reach out and touch who they need to an RN to have their concerns addressed. And we take great pain on the front end to really define those service levels. So we have to have a model in which we are very clear, both sides, on who is doing what with the delivery of service. And at the point you really get all those roles and the responsibilities and the communication defined, and the teams really settle into their roles, you really start driving significant return in terms of the value for both organizations. And I'll briefly cover this slide, but it's an important one. So, in terms of how the service center effectively works remote, we take great pains and we've made great investments as well in ensuring our physical locations are comparable and possibly exceed some of that of our clients. So all our locations have biometric security readers. They're HIPAA compliant in terms of our policies, even beyond just what's in a business associate agreement. Our laptops are all encrypted. The locations have redundant power and internet feeds. We staff them 365, 24/7. And in terms of how we connect into the client, typically it's just over the internet with a virtual desktop. So it's very similar to, it's not the same what our clients are using in terms of accessing the applications. So that's it.
So thank you, Rob, very much. This is Stephanie. So this is just a basic listing of some of the applications that we support for Debbie at St. Luke's. And this is not all inclusive of the applications we support, but this is the listing of the primary applications. And anybody that's in healthcare today knows it's not just the EMR. There's multiple other applications that also have to be supported. So we're also doing a lot of support on those other applications. And that encompasses anything from the perinatal system to even the scanning system. So again, just a representative sampling of some of these applications. How is our teams made up? So whenever we talk about our teams, we have a number of individuals that are on the teams, and they're made up basically, we have associate application coordinators, and those associate application coordinators are individuals that have 3+ years of experience. They're used to doing triage on tickets. They understand workflow and would be considered workflow experts. So they do a lot of queue monitoring and initial look at any of the tickets coming in. Then we have application coordinators, and those application coordinators usually have 5+ years of build experience, and that could be across Epic, but it could also be any of the other supporting applications that we also support. And these application coordinators are responsible for build and to fix issues. Then we have senior application coordinators, and these individuals are responsible for some major build or any of those service requests that may take longer than 4 to 6 hours. And then finally we have the team leads, and these team leads generally have 8+ years of experience and heavy experience too, where they've done multiple builds or multiple support projects. all of our individuals are U.S.-based. All of them are certified in the applications or proficient in the applications that they support. And on the right-hand side is just a general listing of our team's highlights, and these are real members of our team. And so our team has experience not only from supporting the software, the EMR, or the other associated applications, they've also been in the business of healthcare. Most of these individuals have operational experience, so that on the clinical team, we have nurses that are engaged. On the pharmacy team, we have pharmacists that are engaged. And we feel like that's really important to effectively support St. Luke's. And finally, here's just a little listing of our service center highlights, and this is on average for the month. Basically, this is pulled from our clients that we're supporting right now, which we have 4 clients with 2 that we are rolling out or in the process of rolling out. This encompasses about 18 hospitals and about 600 ambulatory clinics. So, and I'm just going to hit on the highlights for this. So for our service desk, which is usually answered, the calls are usually answered by those associate application coordinators or those people with real world experience or understand the workflows. We've got about 15,000 contacts, and we support about 35,000 users. And we're meeting all the key metrics here that most of you are familiar with. So average speed to answer is 85%, less than 36 seconds, and abandonment rate of about 3%. Then on our application support side, we are doing a lot of work there. So you can see that we closed approximately 1,000 incidents, and this is, again, a monthly average. We're fulfilling around 300 service requests. We're performing a lot of maintenance tasks, you know, and there's a lot of maintenance tasks associated with these EMRs and with these other support areas. So we're performing a lot of maintenance tasks. And in doing that, our customer satisfaction rate, which I think is always important to point out, is right at 94% for application support. So now I would like to turn it over to Debbie Gash, who's going to talk about the case study from St. Luke's. Debbie?
Thanks, Stephanie. So you've heard all of the information about the experience that HCTec has brought to the table. I mean, this is basically our story. We had a huge challenge once we implemented our new EMR, in that the amount of work that created just to maintain that system was fairly significant. We went from a HIMSS stage 3.5 to a HIMSS stage 6 overnight, and deployed a whole lot of new capabilities out of the box. You know, just what did the vendor deliver, and said, hey, we'll come back and we'll optimize and we'll make it better after we're up and running. And then our organization saying, hey, we're going to open up some new retail clinics, we want to open up some new multi-specialty, we're acquiring physician practices, and now you have to deploy it to these new locations, and you have the next phases of your deployment that you have to complete. So the work demand was pretty enormous, and so we were spending a lot of resource time just trying to manage that demand and augmenting our teams with consultant labor. And we had leveraged a model during our implementation where we sourced our legacy system management and discovered that, you know what, doing those routine maintenance tasks can be done by a dedicated team, and then we can have a team that's doing project-related work and assisting in more complex support issues. So this model that HCTec brought to us really resonated within our group, as this might be a way for us to meet the work demand and also meet the demands of our customers to just keep advancing the system and then maintain the business and run the business for maintaining the applications. So we did the engagement with HCTec. We started in October of 2016, and we said, let's go ahead and do this model and bring those resources to the table. I also had a lot of employee dissatisfaction, as has been articulated previously. The team really felt like there was just too much to do, and they couldn't keep up with the work and do a quality job. And so others said, I don't want to spend my time just doing maintenance. I want to be able to do the new cool new technology and help advance the system. So this model helped us meet our employee demands as well in helping to relieve some of the burden of the work and also allow them to focus on the things that were very interesting and that they could really feel like they were contributing to the organization. The net result of doing this has actually saved us money. We have eliminated the turnover. We've gone from an 85% retention rate to greater than 95% retention rate. And as Mitch had alluded to, that was costly for us. We're in a very competitive market for IT resources. We have a number of other organizations that use the same EMR we do, as well as we have Cerner here in Kansas City. So they tend to recruit a lot of the talent to go work at the Cerner Corporation. So we were seeing our analyst rates escalate because of this competition in our market. And so finding the experienced resources that already knew it was almost impossible. So we would have to recruit entry-level people and train them and get them certified, and that would take on average about 6 months. So we'd have 6 months worth of compensation that was unproductive, and then also had the training costs associated with getting them to a position where they could actually contribute to the team and do work on the team. So on average, we were spending anywhere between $160,000 and $170,000 just on turnover alone. And we were also augmenting our team with consultants to just meet the new project demands at a rate of $150 to $170 an hour. So by doing this model, we reduced substantially our consultant labor. We were able to leverage our in-house people to actually do the work, and we also reduced our turnover costs. So we have saved over this period of time working with HCTec the $9.2 million, and believe we'll continue to realize savings as a result of those issues. We've seen a dramatic shift in where our staff are spending their time. So historically, just doing break fix maintenance, updating database, the tables and, whatever those aspects of the care and feeding of the system took. The majority of our staff time was spent there in just maintaining the system. We had over 15% of time being spent there. Doing break fix and support work was taking over 30% of our time. And since using HCTec, the maintenance tasks have dropped below 10%, and the break fix has dropped below 15%. And our time spent on enhancements is around 15% of our staff time, and on new development, where over 35% of their time is spent on projects that are strategic in nature, that are growing our organization and supporting the delivery of new technology, which I think helps us to really demonstrate value to the organization. I mentioned the turnover decrease. We have seen improvements in perception of the IT department as a result of this shift. So, issues are being managed, they're being closed, and I think HCTec has actually elevated our service to our organization as a whole, because we're holding them to a specific service level standard and have actually begun to manage and monitor that internally with our own resources outside of the scope of work HCTec has, and we've seen some improvements just globally in our IT support, which has resulted in improved satisfaction. And certainly the doctors are very happy because they feel like the system's more efficient because things are getting taken care of that were problems for them in their workflow. The nurses are happier because they're able to automate processes that might have been manual. So that has been a real win for the clinicians particularly. We have actually documented our case study. It's available for you if you'd like to download it. I encourage you to look at it, and if you have specific questions about our experience, I would be open to responding to those. I also would say one of the things that I have anecdotally just seen as a huge advantage is if we take on a new technology, we can go to HCTec and say, can you help us with this particular product? And if it's new to their portfolio, they have been very able to find the resources that have that expertise on that solution and help respond to our need for support. So they've been able to learn some of our third-party applications. We've spent time training them on those products as part of our transition, and then they can take over the management of those things that are secondary to our EMR, or even solutions that we're in the process of perhaps decommissioning and just need somebody to maintain while we're working on our new system. So I will say that's another kind of advantage I see from a leadership perspective in having that kind of resource that can be responsive to our needs in that way. I'm going to turn it back over to Mitch.
Thanks, Debbie. We really appreciate you participating today. I'm sure everyone on the phone does as well, sharing a real-world story from St. Luke's. Before we get to questions, I really just kind of wanted to wrap up what we've talked about today, really. Just to conclude, what we're talking about here today is a remote team of Epic associates, or EMR associates too, basically doing lights on support. You guys retain all the client-facing work. This is not an outsourced opportunity. I think Debbie will tell you, or she would tell you, that she was approached also by companies who would discuss, almost a full IT outsource, which is pretty risky for hospitals. Our approach is, we just want to take on the lights on support back to that, 75-25 model we mentioned earlier. 75% of the time spent on support, only 25% of the time spent on projects. Our goal within our managed services team is to basically flip that. We're going to take on all the support, and we flip that model on its head, and we allow you to drive to a set cost for support, saving anywhere between 20, 25, 30%. And at the same time, you can dramatically increase, as Debbie's mentioned, the amount of time that your people can spend actually advancing the system forward. So with that, we can open it up to Q&A now. And I think we're going to unmute the phones, as I think I've been told, and see if we have any questions, either live questions or questions in the box on screen.
Great. So we did have a question from Lois Phillips. Stephanie, can you support Greenway Health Success EHS platform?
Well, just as Debbie said, if we do not currently have individuals that can support an application, we can certainly attain that skill set. So I would say absolutely yes. We feel very strongly that we have the capabilities to support any application that's used within healthcare IT. Are there other questions that anyone on the phone has that would like to ask? either from us or from Debbie?
So the phones are still muted, but if you have a question, if you want to just type it in, there should be a place for you to do that. Does this include email, office applications, interface to labs, and medical?
Medical devices as well. And I think the question was, does this include email, office applications, interface to labs, and medical devices as well? Yes, it does. So we are doing regular what is currently identified as Tier 1 support for St. Luke's. So we are interacting and helping with any of those kind of tickets. We're also taking tickets through a self-service portal, so it's not necessarily a call, it's just a contact. We are troubleshooting an application interface to labs right now, and also any medical devices or integration that occurs through medical devices. Where we would not really be able to do are the things that are currently supported by Biomed. That is really outside of the scope of what we would do, but everything else on there, absolutely. Any other questions?
Yeah, Mitch, looks like we've had all the questions we're going to get today. Would you like to close, please?
Yeah, sure. Well, again, I'd like to thank everyone for joining today. Hopefully you found this informative, as Debbie mentioned, and as I'll say the same thing. Any questions that come up, feel free to reach back to us. I think you have contact information to get back to us, and we'll provide any answers and follow-up should they come. So again, thanks for jumping on today, and we will hopefully talk to some of you soon. Thank you.